Dr. Rogé, you take all on you.
Okay, good morning, everyone, and I wish you a happy holiday here. So what we are going to do today is go over things that you are going to encounter on a regular basis when you practice, and if you see children in your practice. So, most likely you are going to do sports physicals, and so we will go over how to detect, the very rare cardiac causes of sudden death. And then if you work as a primary care provider, a clinician during your routine work in the clinic, unless you are deaf, you are going to hear heart murmurs every day when you practice in children. And occasionally you're going to see children with hypertension. And then, of course, you will have to evaluate symptomatic patients. I understand you had a meeting today with Dr. Angoff, so I won't go into very many details about this, just go very quickly about the essential points. So again, primary care clinicians have an essential part in the detection of heart disease in children. So the goal of this introduction to pediatric cardiology is to make primary care providers better equipped to evaluate the child. So when is a primary care provider in the role of detecting heart disease in children? As I mentioned before, when doing a sports physical, on when the PCP detects a heart murmur or hypertension during a routine visit, or when evaluating a child with cardiac symptoms. So let's go first with sports physical. Pre-participation physicals are mandated in nearly every organized athletic program and are performed with the intent of identifying any condition that may preclude an athlete from safely participating in athletic events. And so there is, and I don't know if you already have practiced that, but most clinics are going to have access to what we call PPE, pre-participation physical evaluation. And this was developed by all the medical organizations that have something to do with sports medicine. So you can see the list here: American Academy of Family Physicians, American Academy of Pediatrics, American College of Sports Medicine, American Medical Society of Sports Medicine, blah, blah, blah. It goes on. Every organization that has anything to do with sports injuries and health in general were involved in that. And so this one here that I'm showing, there are two elements: one that the history form that's completed by the patient, and then one physical examination form that's completed by the clinician. The history form, this is at least from the American Academy of Pediatrics website, is available both in English and Spanish. The physical examination form is only in English. So let's go over some of the details. You see in the history form, I marked here with stars, the question that really are there to make sure we are not missing a heart condition that could be a risk for the patient. And these are questions that are very important and that you need to ask when people have symptoms as well. Because again, have you ever passed out or nearly passed out during or after exercise? So syncope, if someone is fainting, you always ask, when does that happen? Does that happen with exercise? The same with chest pain. Have you had discomfort, pain, tightness, or pressure in your chest? Again, if someone complains of chest pain, one key question is, when do you get the chest pain? If it is during exercise, it's a red flag and you need to really be concerned about it. And it is the same with palpitations. Does your heart ever race, flutter in your chest, skip beats? During exercise, again, if it is triggered by exercise, is a red flag. And then, of course, questions Um, uh, has a doctor ever told you that you have a heart problem? Has a doctor ever requested a test for your heart, for example, an ECG or an echocardiogram? So all that, okay, would be very useful for you to determine if there was anything uh, previously found on this patient. And again, did you get lightheaded or shorter of breath than your more? Do you get and feel shorter of breath more than it should be more than your friends during exercise? And then there are questions about the family, um, and again, very important questions. Any family members or relative died of heart problems or had an unexpected or unexplained sudden death before the age of 35. Okay. And then there is a whole list here of genetic cardiac conditions. Now, they are pretty rare, many of them, except for hypertrophic cardiomyopathy. You see 1 in 500, that's pretty frequent. But the other one gets more unusual. So you may see occasionally some of this in your practice, but you may not remember all of them, of course. But if a patient has a family member with this condition, they probably they may remember it was mentioned in the family. So Marfan syndrome, long QT syndrome, short QT syndrome, Brugada syndrome, all these conditions that are listed there. So someone hopefully will recognize that, oh yeah, my aunt had this, or my grandfather had died. And then again, has anyone in your family had a pacemaker or an implanted defibrillator before age 35? So all these are big red flags if people say yes. Okay. And the rest of the evaluation is kind of a review of system of all the different organs that can be causing a problem. And then for you, the provider, you complete the physical examination form. And here is focusing on the appearance for Marfan syndrome. So something to try to remember, it's 1 in 1,000, so it's not very, very frequent, but you need to look for that when you do a sports physical. So kyphoscoliosis, that means that the curve is going in both directions, so front to back and side to side. A high arch palate, pectus excavatum, arachnodactyly, so that's very long arms and fingers, hyperlaxity, and so you have the thumb sign that you may have heard about it. Most people, when they do this, the end of the thumb cannot go past the edge of your hand, but in Marfan syndrome, it goes all the way past that. Mitral valve prolapse is something that you will hear when you listen to them. It will provoke a systolic click, a mid-systolic click. And then as far as the hearts, when you listen to them, a heart murmur, but the very important part of that is that you need to listen in the supine position and then in the standing position, okay, sitting and standing. So if you remember one thing from this talk, when you listen to a patient, you do a physical and you hear a murmur, make sure you listen in the supine position, sitting position, and standing position. And we will see why that's important. I mean, I will repeat it, but basically, when the murmur is louder in the supine position, that's usually what you hear in normal heart murmur, in innocent murmurs. When the murmur is louder in the standing position, then that's a red flag that maybe you are dealing with hypertrophic cardiomyopathy. So we talk more about that when we review hypertrophic cardiomyopathy. So what are the rare conditions that can cause sudden death during exercise? First of all, I just want to let you know, it is a rare event, okay? But it is a disaster every time. There are about 50 deaths a year in the US in high school athletes. But if you compare that, of course, the other cause of sudden death, it is much rarer than, of course, accident, car accidents, drowning, firearms, fires, all those things are going to be more frequent. So there are rare occurrences, but it's something that is a disaster because they are usually healthy young kids. And if you can detect what put people at risk for that and prevent it, that's a great thing to do. And again, heart disease in cause of it's not a major cause of death in children and adolescents, as you can see. It's kind of at the lowest end. So, but again, very important to try to detect those conditions so you can prevent it. And what are those conditions causing death in competitive athletes? Well, we will go briefly over the more frequent, and clearly the more frequent one is hypertrophic cardiomyopathy. You see almost 50%. And if you add idiopathic left ventricle here, with it's not definitive, maybe we don't have all the information to say it is hypertrophic cardiomyopathy, but they are very similar. The next one is going to be coronary artery anomalies, okay? And this was in people less than 35 years of age, so they are a sizable number of coronary artery heart disease, but mainly if you just deal with children, it would be coronary artery anomalies. And then that would be where the Marfan syndrome comes in, rupture aorta. So that's the third one. So let's go very briefly over those three causes, okay? So that we find out how to suspect this condition in order to prevent the sudden death. So what's hypertrophic cardiomyopathy? You can see in the normal heart here, you have the sarcomeres form of perfectly aligned thin and thin myofilaments, okay? And on the biopsy, it looks very regular like this. In hypertrophic cardiomyopathy, the cardiac myocytes are enlarged with bizarre shapes. They are disarray, which give a swirling appearance to the myocardial architecture. You can see that here. So it's a very different picture, okay? And so again, a summary is multiple pathological features, including myocyte hypertrophy, myocyte disarray, and interstitial fibrosis. Okay. So it is an autosomal dominant. So most likely, a first-degree relative is going to have that condition. The problem with that is that there is very, very variable penetrance. So you may have people with hypertrophic cardiomyopathy. They go through life with no symptoms, is never detected. And then in their 60s, they go for an elective surgery, and the anesthesiologist say, well, for safety, they just get an EKG, make sure everything is okay, and boom, they see that there is really an abnormal EKG here. Then they do an echocardiogram, and the patient has had hypertrophic cardiomyopathy, but didn't know. So that's one extreme. The other extreme is people who drop dead as teenagers or young adults. Okay, and again, as a reminder, it is a fairly frequent condition because I'm sure in your practice, when you practice, if you do general medicine, you are going to have patients with Down syndrome, and this is more frequent than Down syndrome. So let's to keep that in mind, okay? So how do you suspect that? Again, symptoms with exercise. That's always a red flag. Chest pain, palpitation, or fainting with exercise is a red flag. You need to evaluate the patient further, okay? And again, I mentioned before, they have a systolic heart murmur, and the difference here, it is louder in the sitting and standing position than in the supine position. So try to remember that when you hear a murmur, always listen in the supine position, and then sitting, and then standing. And then usually, most of the time, you will have an abnormal ECG, like in this case, very deep Q waves, okay? Or you may have just LVH or ST wave abnormality. Now, the other one, the second condition is coronary artery disease. Now, in children, it will be mainly anomalies of the coronary artery. So this is a normal pattern. You have a right coronary artery coming from the right coronary sinus. You have the left coronary artery coming from the left coronary sinus. And then out of that left coronary artery, you have a left anterior descending and a circumflex. You can see there are multiple variations. Okay, you can have both coronary arteries from the right coronary sinus. You can have the left circumflex for the right coronary artery. You can have also the arteries traveling between the pulmonary artery and the aorta. That's going to cause compression at times. I'm sorry, I went to. So you can see there are multiple different types. Now, acquired heart disease is extremely rare in children, but if you see young adults, you are going to see those conditions. And the one I want to mention here is drug-induced, okay? So again, if you are going to see teenagers and young adults, always ask about drug use, because actually, we are going to see on the next slide here that this, even cigarette smoking, cocaine, heroin, amphetamine, all these have been associated with aortic myocardial infarction in young athletes. So always ask about that. If there is any question, you may want to get a drug screening. So how do you suspect these conditions? Again, the family history of heart disease, that would be mainly for the atherosclerotic type. The chest pain syncope with exercise again. So this is always a red flag, needs to be evaluated further. Often they will have an abnormal ECG. And then if the troponin here, if someone had chest pain, the last 24 hours, you want to check on that. If it is like, last time was a month ago, it's probably not necessary. Drug screening, if you hear that, yeah, I like to experiment with this and that once in a while, so you may want to do that. And then lipid panel, of course, looking for atherosclerosis. Now, rupture aorta was the third most common condition, and that is going to be mainly with the Marfan syndrome. Okay, so it's much less frequent than hypertrophic cardiomyopathy, but it's something that you can recognize again with the clinical findings. So if you have someone who is usually tall, they have a high arch palate, they have kyphoscoliosis, pectus, arachnodactyly, hyperlaxity, all those things. So if you find someone like this, before you authorize to do sports, they need to be evaluated further. Do they have Marfan syndrome? Do they have a dilated aorta? Now, bicuspid aortic valve is a very common finding, 1 or 2% of the population, and eventually it can cause aortic root dilatation. But usually it takes a while, so I wouldn't, even if you detect that, it may not be a criteria to exclude someone from sports, but they definitely will need to be evaluated and you hear that by just a systolic ejection click. And atherosclerosis it would be rare in children. Again, you would have a family history of very early cardiac death and hyperlipidemia. Okay, so the use of the pre-participation evaluation form is recommended. And as I mentioned to you before, the same type of questionnaire can be used for evaluation of symptomatic patients. So again, the message here, if the patient has symptoms with exercise or suspicious clinical findings, like for instance, heart murmur louder in standing position, the Marfan phenotype, further cardiac evaluation is recommended before giving the green light for sports participation. So before I go to the next topic, any questions about this?
I don't think so.
Okay, good. I go to the next then. Okay, so next we go to what do you do when, as a primary care provider, you actually detect a heart murmur or hypertension during a routine visit, okay? So let's go over our first case here. One is a healthy 5-year-old boy, and you have been following him for well child care since his birth, okay? And for the first time, you hear a grade 2/6 musical systolic ejection murmur at the left sternal border in the supine position. So what do you do next? Well, first of all, let's see if we can hear it. Christine probably cannot hear it very well, right?
No.
No, okay. All right, sorry about that. All right, so you review the family history, and very important, and there is no history of early cardiac disease, that's good. You review the past medical history, you ask about all the symptoms we talked about before, chest pain, palpitation, dizziness, fainting, yeah, no cardiac symptoms. You look at the growth chart, normal growth, perfect, okay? Then you do a careful physical exam. You heard the murmur, but now you are going to focus and capturing all the relevant information, okay? So you check the fingers and you see there is a quick capillary refill with no evidence of cyanosis. You repeat the oxygen saturation, it is normal. And as I mentioned before, you take the pulse in all extremities, okay? And we will talk more about this, but you take it in both arms, make sure there is no difference. And then if there is a difference, you take between the one with a stronger arm and one in the leg, okay? And then you take the blood pressure. Here, it is a normal blood pressure on this patient. As I mentioned, usually when you have a murmur, you are going to take the blood pressure in one arm and the leg, and the arm that you would choose is the one with the stronger pulse. And then, and as you can see, like in normal people, the it's a little more extreme in the leg. So you will have a slightly higher systolic and slightly lower diastolic. And then you repeat the auscultation. You have a normal S1. You hear a splitting of the second heart sound at the base in inspiration only. And you don't hear any extra sound. No click, no S3, no S4. And you focus on the murmur again. And what you hear is a musical systolic heart murmur, like twanging sounds, like that made by twanging a piece of tense string. And it is louder in the supine position at the left sternal border and harder to hear in sitting and standing position. The murmur is not transmitted to the neck, to the axilla, to the back. The diastole is clear. The lung auscultation is normal. In your clinic, there is no organomegaly. In your clinic, you do a quick hemoglobin and hematocrit, and the hemoglobin is normal. Okay? So, what to do next? Well, you are going to worry, okay, I hear a murmur, the kid is doing well, but I suspect it is an innocent murmur, but am I missing a heart defect here, okay? And so I put here, first of all, you won't have time to go to your private room and get in that position and think about it for hours. You will have to do it pretty quickly. But I put here on the right side a list of the most common cardiac conditions that was in the Atlanta metropolitan area. And these are the most frequent heart conditions encountered in that place, okay? And that's probably the same all over the country. And in green are the conditions that actually you, as primary care provider, are going to be detecting. The other one in gray, those most likely would have been detected either in utero or shortly after birth. But the one in green is the one that you are going to be detected. For instance, ventricular septal defect. Well, why is it not detected in utero and after birth? Well, because the pressures in the right and the left ventricle are about the same in the utero, in the fetus, and then it takes a while for that pressure to drop after birth. And so if the child is healthy, may not have a murmur, he goes home, there is no murmur, and then the first time you see him, and that could even be a large murmur. The first time you see the child, you will hear a murmur, but he's already has signs of congestive heart failure, and you are the first one to detect it. So VSD is definitely a condition that you are going to run into it, and you are going to be the one detecting it for the first time. But when you think about it, well, that will have a pretty harsh pansystolic murmur, okay? So that was not the case here. And it to be heard in all the positions, not really mainly in the supine position. Okay, now atrial septal defect, you know, the problem again in the newborn, you know, because of the pulmonary pressure doesn't drop suddenly, there may not be much left to right shunt, and so there may not be murmur. You'll be the first one hearing the murmur. But again, you go over it. What do I hear if it is an ASD? First of all, if it is an ASD, you feel an increased right ventricular impulse when you palpate, okay? Secondly, when you listen to the heart sound, you have a fixed splitting of the second heart sound. So very important. So you listen to the splitting, you say, oh, sometimes it is split, sometimes it's not. Well, with ASD, it is always widely split. So that's good, okay? And then the murmur is not at the left lower sternal border, like in that case. It is actually at the base. So that's not the murmur. Excuse me. Now, pulmonary stenosis, you know, a severe pulmonary stenosis probably would be detected in the nursery, but a mild one, you know, there may be a murmur there, but it's a little confusing with peripheral branch PS. That's normal in newborn, so people may let it go. But, you know, again, that would be a murmur at the left sternal border going to the back. Usually you would have a systolic ejection click. Coarctation of the aorta. Well, I excluded that. I felt the pulses in the legs and the arms. I took the blood pressure in the arm and the legs. They don't have coarctation. Good. PDA. Oh, yeah, again, PDA. Every newborn has a PDA. You don't necessarily hear a murmur then because, again, the pressures are pretty equal between the left and right side. But if it doesn't close, you may be the first one to hear the PDA murmur. And you may hear it usually earlier than 5 years of age. But what's different with a PDA murmur is that it is a continuous murmur that you hear usually at the left upper sternal border and maybe in the axilla. In AS, again, severe AS would have been detected in the nursery, but mild AS, you may be the first one to hear it, and it's going to be, again, a systolic ejection murmur, mainly at the base, usually with radiation to the neck vessels, and often they would have a systolic ejection click as well at the apex. So you didn't hear any of that in your child, so you conclude it is an innocent heart murmur. So I have the question here, maybe if you could let me know, after everything we discussed, what would you do next? Okay, and you have 3 options here, okay? So option number 1, you reassure the child and parents. 1 has a normal heart sound. We often hear it in healthy children. We call it innocent heart murmur. Option number 2, you order an ECG. Option number 2, you refer to pediatric cardiology for further evaluation. So I'm curious to see, based on what we discussed previously, what would you do? I don't know if you want to, how do you want to give the answer here? Maybe if we see you, Christine, if we see them, they can raise their hands.
Yep, or they can unmute yourselves, and if you want to speak directly. Or type in the chat box if the speaker is not working. I can see them, I just can't hear them.
Well, that's okay.
Oh, here we go, number 3.
Number 3, okay. All right. Well, first of all, I want to say all those answers have plus and minuses. okay? From my point of view, the best one is number one, if, again, if as a provider, you are comfortable with that. That means usually, if you have been in the situation of listening to patients often, and you have been supervised directly by either a pediatrician or pediatric cardiologist who can confirm, your impression, and you feel pretty secure. And, in my experience, I have seen many pediatricians who were able to do that. Because again, keep in mind, you are going to encounter that if you see children in your practice every day of your practice, you are going to hear a murmur, okay? And so eventually, my experience, some people are really confident and comfortable in detecting a normal heart murmur, and they can do it themselves, okay? Now, I have some excellent pediatricians, they could never make the difference because their hearing capacity, they could never make the difference between a normal and an abnormal murmur. So, this is a very individual situation. Now, the ECG, the good thing is that if it is normal, is reassuring. The problem, you have loss of false positive with ECG, okay? And so if that is what you select, it would be reassuring most of the time, but once in a while you are going to have a positive EKG, and it is a false positive when you refer the patient. The problem with referring to pediatric cardiology, of course, that's good for the profession here to get more referrals. The problem is it depends where you work. In some places, it takes a while to get a referral, and we are going to talk about this. That causes lots of anxiety in people because they have to wait, and they worry. They say, "My kid has a heart problem. It's terrible. What are we going to do? Blah blah blah." They keep thinking about it until they see the specialist, and it is also an inconvenience for many people, depending again on the situation. They may have to take the day off. They may have to travel. So none of this situation is the right answer, but it depends on the context. Okay. Okay. Why is that going to the next slide? Christine, uh-oh.
You try clicking, I'm sorry, can you try hovering over the left
Okay, there you
corner?
go. There you
There
go.
we
Okay. All right. Okay. So in summary here, most children have a heart murmur heard at some time during their childhood. So if you are going to see children in your practice, you are going to see this on a regular basis, okay? A very small percentage have a heart problem. Most of them have an innocent heart murmur. So there are several types of innocent heart murmur in children. This is the one we discussed, that's a Still's murmur. It could be also the pulmonary flow murmur, systemic flow murmur, called also supraclavicular systemic bruit, venous hums, okay? Now, again, ideally, the primary care provider is comfortable after a thorough clinical evaluation in making the diagnosis of innocent heart murmur and reassuring the parents. In that case, an electrocardiogram is not indicated because false positive may increase the anxiety of the family, and we require a referral to pediatric cardiologist. So again, the level of comfort of primary care provider depends on training and hearing capacity. But I want to stress the fact that reassuring the parents can be a challenge, okay? Because this is what goes through the mother's mind after you tell them that the child has a heart murmur, okay? And this is a study that was done about 20 years ago. When you tell that the child has a heart murmur, this is what goes through her mind. Uh-oh, half of the people said, my kid is going to need medication. Oh, he's going to be restricted from sport. The third thing is going to need cardiac surgery. And then they think that the other kids have a risk now. I have to worry about my other children too. And then almost 20% say, oh, it is happening because I did something wrong during pregnancy. And then about 13% think, oh, my kid is going to die early. So, lots of anxiety. Now, you are in Arizona, I think, but in California, there is a new program called dyadic care, which is when we see infants up to 5 years of age, we can actually assess the mother and the caregiver um, behavior health issues, and this is mainly for depression, anxiety, and things like that. And so, but let's see why there is so much anxiety. Okay, well, number one, most people have a parent or a friend who has died of heart disease, because let's not forget that heart disease is the #1 cause of death in the US. Okay? And again, very rare to have sudden death in a healthy athlete, but it is such a awful, dramatic event that it is always reported in the news or news media. But also, let's not forget that the heart is the most important organ in the body. And let me tell you, this is not only what cardiologists believe. So if we go back to the origin, the Homo sapiens, we all come from Africa. So let's go first to Africa. In ancient Egypt, this is what happened after you die, right? On your way to your afterlife, you have to travel to the Hall of Mat. And there is a god here with an interesting face, god Anubis. He weighs your heart. So he puts your heart here on a scale, okay, and he puts a feather on the other side. Now, if your heart is as light as a feather, then you pass the mat test and you go into your afterlife. However, if it is heavier than a feather, there is another god here, Amut. It looks horrible, but he's ready to eat you up. So that's what they believed in Egypt, that the heart is really the organ where the soul resides. And you may know in the Aztec culture and other Mesoamerican cultures, the heart belongs to not only to the individual, but also to the sun gods. And the sun gods, they sacrifice themselves and fight against darkness so man can survive. And so in return, man must offer a sacrifice to the sun gods. And the best offering is a beating heart. So what they do, they take a live person, they go through the abdomen, the diaphragm, they take the heart, and they give it offer to the god. Now, this is not the sun god, but I like, this is one of the gods from the Aztec time. It is very colorful, so I put it there. So as far as I know, this is not done anymore, but going all the way from the north of the Americas, from Quebec, all the way to the south, to the tip of South America in Chile, Punta Arenas, you are reminded all the time that the heart is a sacred organ. And then if we go to different cultures, if you go to Indian cultures, the little space within the heart is as great as a vast universe. And in contemporary European culture, it is only with the heart that one can see rightly. What is essential is invisible to the eye. So again, all these to say are important. Whatever you do has a big impact, and you should be aware of that. So if you can reassure the parents right away, it's probably better in that context. But again, only if you are comfortable. Again, if you send them to cardiology, it is fine because they will have the right workup, but there will be lots of anxiety in between. And if you can help the parents with their anxiety, that's wonderful. Okay, let's go to case 2. So we done right after. Arthur is an 8-year-old boy who is scheduled for his routine well child physical. Now, Arthur has been followed by a colleague of yours. You review the chart and see that he is overweight, as mild hypertension and had normal laboratory results, normal lipid panel and renal function. Arthur was seen a year earlier by a pediatric nephrologist who diagnosed mild primary hypertension related to overweight. Now, it takes too much time, but if we had time to ask you the question and see what you would document, but let's go to the next thing. What you do next really is to document the blood pressure in the four extremities. So here you see the blood pressure is the highest in the right arm, 138/65, and is lower in the legs, 110/60. And then when you do auscultation, you hear a grade 1/6 systolic ejection murmur that's heard at the base, in the axilla, and the back. So what do you suspect? Again, I don't know if we have time to. You want to tell me what you suspect? Anyone?
Don't see any answers.
What's that?
I don't see any answers yet.
Okay, no answer yet. Okay. All right. Well, it is
COA.
That's right. Coarctation is suspected. Very good, very good. Okay, very good. So again, you repeat that, you measure the blood pressure in the four extremities, you see that it is really abnormal. And what to do next? Well, in that case, it's not a bad idea to order an ECG, because now you know for sure there is something wrong here. You order an ECG and a chest X-ray. Now the ECG is normal, and the chest X-ray most of the time is going to be normal also in mild coarctation. But if it has been going on for a long time, I have seen actually adult patients who had coarctation, they were not detected, and they were asymptomatic all that time, but they did have this knob here, rib notching, that is evidence of collaterals, okay? And then occasionally you can clearly see a 3 sign here, but most of the time it's going to be normal. But in any case, anytime you have a blood pressure difference like this between the arm and the legs, for sure you're going to refer to pediatric cardiology. And what they will do is they will do an echocardiogram. And the echocardiogram, this is the ascending aorta, this is a transverse arch, and here you see a narrowing between the arch and the descending aorta. And then with the Doppler, you see increased velocity, okay? Now, what they do next depends a little bit on each place. If it is a tertiary center where they go straight to surgery, they may get an MRI that shows also the obstruction here and here, but it also shows very well the collateral circulation. But most places, they would do a cardiac cath. And again, with the angiogram, you see the coarctation of the aorta there. And then in terms of treatment, if you do in the cath lab, you put a stent there and you relieve the obstruction. Otherwise, you need surgery, okay? So coarctation of the aorta is not terribly frequent. It's 6% of congenital heart disease. But how do you suspect that again? Because you have abnormal pulses, okay? So if you remember one thing again from this talk, when you do a physical exam, always feel the pulse in both arms, and then one arm and one leg at the same time, to looking for radiofemoral disease, okay? Again, you will have systolic hypertension in one or two arms, and this is one or two arms because some defects are past the left subclavian, so you have only one arm, and usually it's the right arm that's going to be with higher blood pressure. So that's why it's important to take in both arms, okay? And then there will be a difference in the pulse between that stronger pulse in the arm and the leg, and then there will be a pressure difference, okay? And then there would be a systolic ejection murmur in the back and at the base, if combined with mild AS and systolic ejection click. Often you have a bicuspid aortic valve as well as a coarctation. So the message here is that you rule out coarctation of the aorta anytime you encounter hypertension in children, okay? Because primary hypertension, it happens more and more now that we have lots of obese kids, but it is still not the most frequent cause of hypertension in children, okay? You have to exclude all the secondary causes. So, coarctation, renal disease, all these things you have to exclude before you say this is primary hypertension. Okay, I think we have only a few more minutes, so briefly with cardiac symptoms, based on everything we discussed before, you are going to collect the data and you are going to put into one or two category. In the reassuring where you are not going to worry too much if everything is normal. So you have normal growth and development, you have no symptoms with exercise, there is no family history of